models that are designed for decision makers, in contrast with the more conventional type of prediction model, which is explanatory. During the next 30 minutes or so, we'll talk about some of those distinctions. Those distinctions could influence your design of these prediction models. Two examples from our work at Kaiser Permanente. These are nephrology examples. This work is conducted by the Predictive Analytics Unit, where I work at Kaiser Permanente's Center for Health Research in Portland, Oregon. 10 years ago, the National Kidney Foundation released its clinical practice guidelines for patients with chronic kidney disease. And one of them recommended referral to nephrology of patients with chronic kidney disease when their kidney function dropped below 30 milliliters per minute. That's the start of stage 4 kidney disease, stage 5 being end-stage renal disease. And the basis for recommendation was stratification on one characteristic, the estimated GFR, which is a measure of a patient's kidney function. So these were published. One of the nephrologists at Kaiser Permanente Northwest approached us at the Center for Health Research and thought that we might be able to do a more effective job at risk stratification if we would consider the kidney function in addition to several other routinely available characteristics, such as hypertension. And so we have to develop what we ultimately call the kidney credit score. And that's the paper that you see right here, which was published in the American Journal of Kidney Diseases. This is a risk score or a predictive model. They go for names for predicting the 5-year risk that patients would develop end-stage renal disease and require dialysis or kidney transplant. The jargon in nephrology for that would be renal replacement therapy. And a retrospective cohort study that we conducted at Kaiser Permanente Northwest. And you can see my colleagues listed there. The nephrologist who approached us is Micah Thorpe, currently Chief of Nephrology at Kaiser Permanente Northwest, our biostatistician at McGill University, Robert Platt, and Dave Smith, also at the Center for Health Research. The reason I have the Voltaire quote at the bottom is the original inclination was to try to fund the work through age. So we submitted an R21 proposal to NIDDK, and they were completely uninterested, would not even score it. Their criticism had nothing to do with the statistical methods. It had to do with data. They were interested in the retrospective data that we had, in part because they thought that we were missing certain laboratory values that would be essential, and more the problems of missing data. Our decision maker, Micah Thorpe, needed a prediction model that would work with the data he had, not the data that he wanted to have. And so sometimes the perfect explanatory model built on a prospective cohort study with all of the laboratories and other clinical insights that you would like, a good enough prediction model that you need pragmatically in routine clinical practice. So let's talk a little bit more about the kidney credit score, how those pragmatic considerations influence the design. So the Kaplan-Meier failure curve showing the cohort of almost 10,000 patients with chronic kidney disease identified Kaiser Permanente Northwest in the late 90s, and then followed up to 5 years for the onset of end-stage renal disease and the start of dialysis or early kidney transplant. The cohort has been scored according to a prediction model. I'll talk a little bit more about the characteristics that went into that in a minute. And the cohort was divided into quintiles. And so we're seeing for each of these Kaplan-Meier curves is 2,000 patients and their experience. The dark line is showing you what actually happened to the patients in terms of their progression onto dialysis or transplant. And although a little harder to see, the dotted line is showing you what the kidney credit score predicted would happen to those patients over the 5 years. Substitution model you need to put two questions to its performance in terms of its internal statistical validity. The first is how well it separates out the high-risk from the low-risk patients. And as you can see from this graph, the patients in the top curve have a much worse prognosis. About 18% of them will ultimately go on to start dialysis or get a transplant after 5 years. 40% of the patients, those in the bottom quintiles, have hardly any risk of going on to renal replacement therapy. So in a sense, the prediction model has good discrimination. The question that you want to put to any of these prediction models concerns how accurately the predictions match what actually happens to the patients. And it's the extent of the agreement between that dark line and the dotted line. And you see that for each of the quintiles, the agreement is within about 1%. And so the jargon for this is that it has good statistical calibration. Next slide, what we're going to do is take a look at a hypothetical patient who belongs to that top Kaplan-Meier curve, so that you see how the model works at the patient level. So, a medical patient who belongs to that cohort. It's a 4-year-old man with no history of diabetes. He has blood pressure, but 90%, or hypertension, but 90% of the patients in this cohort do. We've early assigned him late stage 3 chronic kidney disease. He has an estimated GFR of 34 milliliters per minute, which is interesting insofar as he would not meet the criterion for referral to nephrology under the National Kidney Foundation guidelines. Did not assign him anemia. In order to assign the risk score points for this patient, you run a Cox regression model, and you're just translating the hazard ratio from that model to find a certain number of points. The points themselves are on an arbitrary scale in much the same way that a credit score's points are on an arbitrary scale. But they facilitate the ability to compare the relative strength of the prediction across characteristics. And they can be handy if you're going to be using restricted cubic splines or other approaches to nonlinear relations. So in this particular instance, you add up all of the risk score points across those 6 characteristics, and this patient has 176 points. You compare that to a separate table, which I don't show here, and you can see that that patient has at least a 20% predicted risk of going on dialysis or transplant, even though that patient would not be flagged according to National Kidney Foundation guidelines as needing the attention of nephrology. All of these characteristics were the electronic health record or the other databases at Kaiser Permanente. There were any missing data. Even for hemoglobin, 95% of the patients had a value. And it seemed a shame not to take advantage of this information that was really sitting there to try a more accurate job at predicting the risk instead of depending on that sole characteristic, the estimated GFR. Head-to-head comparison of the National Kidney Foundation guideline in the left-hand column, then our prediction model with a cut point of 10% predicted risk or higher. And we check that cut point so that we could hold the workload for nephrology constant on either of those scenarios. So the Department of Nephrology, which has 7 nephrologists, would need to see the same number of patients under either of those strategies. You can see that the prediction model with the 6 characteristics has higher sensitivity than the standard guideline. The predictive value is a little higher at 27% versus 20% for usual care. Probably are making a better return on the time invested in seeing those patients because they're seeing those patients who are more likely to actually go on to dialysis and need the attention of nephrology for placement of fistula, et cetera. And then you have some of the classic performance statistics for these models. This is the bootstrap-corrected C statistic, which is on a scale from 0.5, meaning that it's no better than guessing, up to which would indicate a perfect prediction. And again, what this is really showing you is that using 6 characteristics will give you better discrimination than using the 1 characteristic. As we talked about earlier, the calibration is actually more accurate within 1%. So this is one of the earliest papers on the important distinction that I've mentioned between the explanatory research, which is typical of the sort of research that NIH funds, which is aimed at an understanding, pragmatic research, which is aimed at supporting a decision, namely, which of 2 treatments or other strategies should we prefer. Statisticians published this paper. It was translated into English in the late 1960s and published what at that time was called the Journal of Chronic Diseases. Today this journal is called Journal of Clinical Epidemiology. And it's such a useful paper for understanding this distinction that they republished it in 2009 as part of a special issue on explanatory and pragmatic issues. This paper deals especially with randomized controlled trials, but many of the insights that they offer philosophically about how you design studies are equally applicable to developing prediction models. This is a diagram from one of the papers in that issue, that May 2009 issue of Journal of Clinical Epidemiology. This is the Predictive diagram by Thorpe and colleagues, and it developed to help investigators design more pragmatic studies, or at least understand the extent to which their design choices were placing them closer to the explanatory part of the spectrum, or pragmatic. So a classic explanatory study would be a phase 3 randomized controlled trial that might be submitted to FDA, where the principal objective was to demonstrate efficacy, the extent to which a product could work, versus more explanatory is the extent to which an intervention will work under more routine conditions. And we're not going to go through all 10 of these, but I wanted to highlight 2 of them here that are salient to the particular score that we're talking about. It's possible to develop these prediction models using data from randomized controlled trials, but in many instances, the investigators will be constrained by the eligibility criteria of the trials that may not be as applicable to the routine practice setting. The other advantage of using large data sets of the kind that we have at Kaiser Permanente and other health plans is that you're unable to measure those outcomes that matter to decision makers and patients. In this case, instead of having to depend on the doubling of serum creatinine, we're able to look at those patients who actually progress on and chose to either start dialysis or transplant. And so the development of pragmatic prediction models is an especially good fit for the sort of data that the DECIDE network has long funded. This is the most important slide in the seminar. Design thinking is an approach that was pioneered by the world's top design firm, which is DO in Palo Alto, California. IDEA for helping Apple develop the first mouse. Tim Berners, their CEO, and he published a book on this topic by the same. And conveniently, he has a more concise version which appeared in Harvard Business Review a few years ago. I call your attention to one particular point that he makes in that article that I found invaluable for developing pragmatic prediction models, and the power of prototyping. So in contrast to a typical NIH-sponsored study, where you're encouraged to develop a protocol and then lock it down to the work and then bring it back to the decision maker once you're finished, the value of prototyping is that you're going to show a very early draft of what you're doing to your decision maker, as often as weekly. And that's what we do with the Department of Nephrology and our colleague Mike Thorpe, so that he's collaborating on the development of this throughout. And the reason that it's important to show that prototype to the decision maker as often and as early as possible is that they're likely to give you helpful feedback. And you're more likely to take that feedback. And so there are any number of decisions that we changed in development of the prediction models because of the good and early feedback that we were getting from the people who would be using it in routine practice. So next example may be more interest to colleagues in the DECIDE network. This is what we also developed at the request of Micah Thorpe for the Department of Nephrology, where we were predicting the risk of elevated serum potassium or hyperkalemia in patients with chronic kidney disease who were starting either an ACE inhibitor or an ARB. In our population, it was overwhelmingly ACE inhibitors, in particular lisinopril. A list of the authors. We published this paper in Pharmacoepidemiology and Drug Safety a few years ago, and I bring it to your attention because it's a concise summary of many of the references that you would need if you were interested in trying to develop a prediction model to predict the harms or benefits of patients who are starting an intervention. Typical of some other scores that I want to mention, the FDA recently sponsored a study by Jim Kuntz, a colleague of mine at Kaiser Permanente Northwest, to develop a prediction model that would predict the onset of Clostridium difficile infections in patients who were starting a particular class of antibiotics, the fluoroquinolones. Another colleague of mine, Dr. Alan Go at the Division of Research, has developed a prediction model that will predict bleeding in patients who are taking warfarin as prophylaxis for their atrial fibrillation. And so there are any number of these prediction models that are an especially good fit for people working in comparative effectiveness, where you may have already assembled a cohort of new users of an intervention for the comparative study, and then this fits well as perhaps a third aim, so making the most of that data. And in instances, including the one that we're going to talk about now, it's the only prediction model of its kind. Is a similar display to the one that we were looking at earlier with the Kaplan-Meier failure curve. This is a risk predictiveness curve, and we've divided the cohort of patients into quintiles based on their predicted risk. And so what you see along the x-axis here. And then the circles are showing you the actual observed risk within the patients in that quintile. And so kind of a risk predictiveness curve is addressing the same questions we discussed earlier. First, discrimination, the extent to which a prediction model can separate out the highest risk patients from the risk patients. And see that although there is a tenfold separation in the instance of hyperkalemia between those top and bottom quintiles, it's not nearly as impressive as the discrimination that we looked at in the first example. Second question you want to put these models is the extent to which their predictions are accurately characterizing what happens to patients. And in this instance, the prediction model has good calibration, and that's because these open circles sit very close to the risk depicted line, so that at each quintile, what would happen to the patients and what actually happened to them agree well. You can see here in the top quintile that prediction slightly underestimated what happened to the patients at the highest risk. This is a report of approximately 5,000 patients at Kaiser Permanente Northwest, and we're looking at their 90-day risk of developing hyperkalemia as determined either by laboratory values or by diagnosis code, perhaps because they needed to go to the emergency department or be admitted to the hospital. We're going to talk a little bit more about a hypothetical patient who belongs to this top predicted risk in the next slide. So again, a hypothetical patient, it's an older patient, and older predicts an increased risk of hyperkalemia. He has worse kidney function, which also predicts a higher risk, and diabetes independently predicts a higher risk. For the sake of simplifying the example, I've decided that he won't have heart failure, which would increase the risk. He's not starting on a higher dose of an ACE inhibitor, which would also increase the risk. And he's using potassium supplements or potassium-sparing diuretics. All characteristics were routinely available in the electronic health record, so there was no added cost to collecting any of this information. And just as in the last example, we put through a Cox regression model, and we were able to calculate hazard ratios for each of these characteristics, and then the extra step to translate that hazard ratio into a specific number of risk points. In this example, the fact that the patient is a little older and has worse kidney function and diabetes is sufficient to place him in that top quintile of highest risk patients who really need to have laboratory surveillance for the possible risk of hyperkalemia. This is a paragraph that's in the discussion section, and I think it helps to illustrate some of the trade-offs that you face in developing pragmatic risk scores versus explanatory ones. When we wrote the protocol originally, we wanted to use the National Kidney Foundation's definition of chronic kidney disease, which requires 2 estimated GFRs that are separated by at least 90 days. That's the chronic part of chronic kidney disease. If you only have one poor estimated GFR, less than 60 milliliters per minute, it's possible the patient has acute kidney disease and not be confirmed as chronic. But we actually looked at the practice patterns at Kaiser Permanente Northwest during this period, which are overwhelmingly driven by primary care and family medicine. We found that many of those providers treated empirically without waiting to confirm whether the kidney disease was chronic. So you face a trade-off. You can stick with criteria that the National Kidney Foundation has specified and would have benefits statistically, and you would probably have less regression dilution bias for that one characteristic, and that the apparent strength of estimated GFR be larger. You'd probably have better discrimination, for example. And yet, that required the 2 estimated GFRs would necessarily work in practice because it doesn't fit the practice patterns in primary care at that time. And so not necessarily a correct answer, but the extent to which you can make a commitment to developing pragmatic tools will help outline some of the trade-offs that you're going to face in designing these sorts of tools. So that's just one of many possible examples that you would need to be aware of if you were designing something for a specific setting. We're in a very fortunate situation that we get to talk to the decision makers who will use these tools, and we have a lot of familiarity with the particular population and the setting into which they would be put into practice. It's much harder if you're designing this in a more abstract way for use by some decision maker that you may not have identified yet. Is a list of recommended readings. I would start with BMJ's 4-part series on prognosis and prognostic research, which was published in 2009. And they take you through review articles on developing, validating a model, and then comparative effectiveness or evaluation of that model. The bottom reference there is from a group that's been very productive in the UK. And they develop a series of, I think they have as many as 10 risk scores that are developed with data from electronic health records and then validated with a different set of records from the UK. And patients automatically, much like ours, are designed to work so that providers don't need to manually enter those characteristics into a risk calculator in order to predict the risk. So the particular paper that I've cited there is the Q Research 2 model to predict cardiovascular events. It's a competitor to the Framingham Heart Study. The issues that they have worked through in developing these pragmatic tools will help you address the questions of a similar nature that you might have in your setting. The bottom of that shows their website there, the Q Research Group. And you can download some of their prediction models even as apps for the iPhone or their smartphones that would allow you to calculate a patient's predicted risk of cardiovascular disease. They even have a similar competitor to ours that they call Q-Kidney for predicting end-stage renal disease. That you'd like to undertake this sort of work, you'll probably buy a copy of Steyerberg's recent book, Clinical Predictive Models, A Practical Approach, which is less statistically oriented treatment, but will cover everything that you would need to know about developing and validating these sorts of models. Same author, Steyerberg and colleagues, published a review paper in Epidemiology in 2010. That's the second reference here, that covers the state of the art on statistics for these sorts of models, and in particular, the statistics that have been developed over the past few years about the incremental benefits of including a new characteristic in an existing model. This field is actually Frank Harrell at Vanderbilt, and this is his book, Regression Modeling Strategies, which contrasts with the Steyerberg book in that it's a far more mathematical and statistical treatment of the issues. It's for a second edition in early 2013. So I think that is all that I have, and I'll open it up for questions.
All right. Well, thank you very much, Eric. I'd like to start off in thinking, sort of carrying from what you were talking about towards the end there on these books. I had experienced a little while ago. I was giving a lecture on propensity scores, and afterwards somebody was came up to me and talked to me and said, "Oh, they're involved in prediction modeling," and it was interesting to me in thinking that there actually might be different camps of prediction modeling versus propensity scores, and some of the aims and goals of those two tasks could be different. Perhaps you had some thoughts maybe you could share with us on how develop prediction model differs from, say, propensity scores or disease risk score building.
Yeah, it's a great question. I think what I'll do is I'll go back to one of these examples here and discuss that in the context of, let's see if I can, So this is a good example that would show some of the trade-offs between those two. When you develop a prediction model that you're hoping to use, again, either in the same population or a different population, one of your concerns is the extent to which you would overfit the data. So in our case, you can see that we've got a cohort of 5,000, but 145 events. And as a rule of thumb, you need at least 10 events per degree of freedom for every candidate predictor that you consider. And so in this case, you're very constrained by the number of characteristics that you can consider and the number of degrees of freedom within the characteristics. So we had to use, let's say, restricted cubic splines with only 2 knots for age and 2 knots for the estimated GFR value. If we had a bigger data set with more events, we would have been able to do a better job, probably, because we would have used more degrees of freedom. Earlier, we wouldn't have dichotomized it as just yes, no. We looked at the severity of that heart failure, because the decompensated heart failure is yet another elevation in that risk of hyperkalemia. And then you might have looked at the severity of diabetes or other things. So the reason you care so much about overfitting data is that the performance of the discrimination, the calibration, and some other statistics will deteriorate when you go that to a new population if you've overfit it. But that's a concern for most of the propensity scores, where you're going to use it solely in the data set where you developed it, and you're not interested necessarily in its applicability to future studies for future populations. So that would probably be the most important distinction between those two types of modeling strategies. maybe had other considerations in mind, John.
I think that for sure is an important one, and I think the other thing I was thinking about is sort of the purpose of the exercise was, that is, in its prediction, and with the propensity score, it isn't necessarily prediction; it's removing confounding depending on how you use the propensity score, and that different aim or different goal of the exercise also changes maybe some of the things that you would do in the course of building on.
Absolutely, and another sort of nuance to that is that with the prediction models that are going to support a decision, you spend a lot of time worrying about the most relevant cut point. Framingham heart studies model to predict the risk of heart, either myocardial infarction or coronary heart death, has historically over the past decade been set at a 20% risk. Going to revise that, it's due any month now. They may lower that risk threshold. So you get an entirely different level of discussion about where you're going to draw the line for making a decision that wouldn't necessarily have with a propensity score.
It was interesting in preparation for this webinar. I happened to visit the website for the Framingham risk score and entered my data. And I'm happy to say I have a less than 2% or approximately 2% risk of a 10-year risk of heart attack. So we think I'll be around for a while. But that information, though, I was thinking it translates then to a dichotomous kind of driven by the clinical considerations of if I prescribe a statin for this patient or not, and that as modeling all of the details of risk that are so important when you make a consideration that at the end of the day it's just a dichotomous choice that you have to make.
Mm-hmm.
Sort of along these lines, are there any different considerations in modeling a continuous outcome instead of something that's dichotomous?
Yes, and I'll tell you some mistakes. Let's look at one of these slides here. So if I had it to do over again, I would not have made some of these choices. Age was continuous, and we left that continuous using a restricted cubic spline with 5 knots, and so that was a reasonable approach. And you do that not only because you're picking up the ability of a nonlinear relation in that, you get more statistical power anytime that you can preserve a characteristic as opposed to dichotomizing it at a particular age. You lose a lot of statistical power that way. For blood pressure, we had blood pressure values from the electronic health record, but we also had diagnoses, and we just dichotomized it. And I think that was a big mistake. The Permanente Northwest has recently sponsored us to develop a revised version of this kidney score, but specific to patients with stage 3 kidney disease. And in that newer work, we have used the actual systolic blood pressure readings, restricted cubic spline, as opposed to dichotomizing it, so getting more discriminatory power out of that. That's especially important in this example because, in fact, 90% of the patients in this cohort have hypertension, and so dichotomizing it the way that we did was a poor choice. And the same would apply to we should have left hemoglobin as a continuous variable and at least checked with restricted cubic splines or fractional polynomials whether there was anything nonlinear that needed to be accounted for in that model. So although this model has excellent statistical properties, there's still a lot of room for improvement, at least theoretically, if we had adhered to some of that advice.
Eric, I was thinking of, actually, when I was asking the question originally, I was thinking of what if it's a continuous outcome rather than a categorical outcome? Are there different concerns?
I don't have any experience developing for a continuous outcome. Most of what will matter to the decision makers, at least in my experience at Kaiser Permanente, would be more dichotomous or event-driven. You could imagine that you were trying to predict. You could, all of the principles that we've been talking about here can still be used with linear regression, predicting continuous outcomes. But you don't see many examples of that in practice.
And I think we've talked around this issue of the mechanics of doing the prediction. I just wanted to clarify for my own purposes that typically it's done using logistic regression. You have a data set that goes in with the outcome, yes, no, and then a lot of different prediction variables. Anything you'd want to add to that?
Or Cox regression. So I think most of the examples that I see today, including the research examples that I put up there, are about Cox regression, just because it has the additional advantage of dealing with the censoring. But it doesn't have to be fancy. Cox regression turned 40 this year, and it's amazing how far you can get with that very old tool. There are regression models that you could use that would be more sophisticated, but most of the time you're going to get the prognostic value out of a fairly straightforward approach with either logistic regression or Cox regression.
You mean a term I wasn't familiar with. Was it a bootstrap corrected statistic? Can you expand on what that is?
Sure. So the boot-corrected statistics are accounting for the extent that you may have overfit your data, and there may be some optimism in the size of the hazard ratios. And so it's going to resample your data and penalize you for any overfitting. Now, in both of the examples that I discussed today, we had a very modest overfitting. There's a way to measure that with the slope shrinkage statistic. And in both examples, it was about 0.95, meaning that we had very modest potential for overfitting. So they're not going to see much of a difference between the bootstrap-corrected C statistic and the naive C statistic. But that's supposed to give you a better idea of what you would get if you were to apply the kidney credit score in a new set of patients, an updated set of patients in the same population, because you would be pre-penalized for the extent to which you would overfit your data development cohort.
Okay. We have an audience question. Can you comment on the use of recursive partitioning rather than regression modeling for prediction? Any thoughts on that?
I have no experience with recursive partitioning. A colleague of mine who's a statistician at KP Southern California knows a lot more about that. His name is Jason Jones. And he would be the one. I can give you his contact information to follow up. The recursive partitioning is covered in Frank Harrell's book. The recursive partitioning is a little different in you're letting the data make some of those choices for you. So it's closer to the machine learning approach, if you will. Whereas all examples that we've talked about here today are really clinically driven. We've asked the nephrologists and searched the literature to find out which characteristics were, and we forced them into the model. We're not picking anything based on its statistical significance. And it turns out, because these are such established risk factors, they're statistically significant. But there's a whole school of thought pioneered by Frank Harrell and others based on simulation that you do not want to pick your characteristics for the prediction model based on their statistical significance, especially in a small cohort kind that we were just talking talking about for hyperkalemia, then you're going to run the risk of overly optimistic hazard ratios or odds ratios, and that you'll perform worse when you validate it in another population, as opposed to picking characteristics that have a long-standing history of being at least modest, if not strong, predictors of a particular outcome. And then there's a little bit more to the role of patient preferences. That's a fascinating area in which I have zero experience. All of our prediction models are designed to support a physician's decision with no expectation that the prognosis would ever be shared with the patient. I think if you're going to share those findings, and John gave a great example of, let's say, the Framingham Heart Study, prediction for the 10-year risk of cardiovascular disease, you need to take additional steps in order to help the patient understand what an absolute risk means and some of their nuances around that particular thing. But in our case, we find that if you're going to ask physicians or providers to manually enter that information into a risk calculator, a lot less likely to ever be used, at least routinely. And everything that we do is designed to be scored automatically, and the kidney credit score is a good example of that. Every week, IT updates that for the entire population of 470,000 patients. And then those findings are given to the Department of Nephrology so that they can look through them, make sure they're not missing any high-risk patients, make sure that they're seeing patients at highest risk in the right sequence. So it gives them a way to prioritize their caseload. The patient is never shown that particular number. And I think you'd need to do a lot more work in the shared decision-making and maybe even involve a different set of expertise if we're going to do something like that.
Eric, based on that, the way you described it, I'm wondering if going beyond pragmatic, given that it's all done through the IT side of things, that you could imagine having a really complex model, because then you're not limited to what can be done sort of by hand by the clinician in the office. It's something that all the calculations are done in the background and you do a score.
That's absolutely right. And we just finished a larger prediction model for the onset of Clostridium difficile in the outpatient setting, and I think it has 22 characteristics, which would be absolutely overwhelming for a provider to enter manually. The model has spectacular performance, and we had plenty of events. I think we had more than 600 infections across two different regions. We were able to develop something that had better discrimination and other characteristics. That's a partial answer to one of the other questions that I see there. People are asking about advantages of using the electronic health record data as opposed to e-patient self-report or other sources of information that you might have, let's say from a randomized trial. Here's a iteration of that particular point. The replacement registry at Kaiser Permanente is very interested in risk calculators, and I link up the prospectively collected data that the surgeons are collecting with inside the electronic health record, including older routine labs and diagnoses and other history. They're able to do a better job at profiling severity of a patient's disease. So they can ask dichotomously, the patient has diabetes, or they may know their most recent hemoglobin A1C. But if you're able to use the totality of that patient's history, you can count the number of complications of diabetes and severity that they have automatically, and that's going to give you additional prognostic insight. Over the longer term, especially patients who stay in an integrated healthcare system where you have longer history on them, as opposed to just some characteristics that you made at a particular point in time, at least in principle, you ought to be doing a more effective job at prediction.
Are there other questions from the audience? Okay, I think I'm out of questions, and the others in the audience here are out of questions. So I'd like to thank you, Eric, for giving the presentation. It's been very illuminating, and again, to plug next month, we have Sebastian Schneeweiss to talk about sensitivity analysis ER. Thank you.